Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're going to be going over the antipsychotic medications for schizophrenia and some complications and adverse effects that you guys need to be aware of. Before we get started, as always, I'm going to ask you please support me and this channel by liking this video. Go ahead, press that like button, subscribe to my channel if you haven't done so already, and don't forget, I have audio lessons available on my website, nexusnursinginstitute.com. So guys, let's take a look. At this table, you will see the long-acting injectable antipsychotics. The most important antipsychotics you need to know, guys, Haldol. You see Haldol? My nails, I need to get them done, so don't worry about that. Haldol, that's the first generation antipsychotic. You need to know that. Make sure you guys take a look at the nursing intervention. Second generation antipsychotics, your Zyprexa, your Risperidol, and your Abilify. You need to know those medications. You need to know that those are antipsychotics. Now, let's talk about the first generation antipsychotics. Look what it says. It says first generation antipsychotics are dopamine antagonists in both the limbic and motor centers. Blockage of the D2 receptors in motor areas causes EPS, your extrapyramidal side effects. You need to know these side effects that go with these medications, these antipsychotics. Number one, acute dystonia. What is that? Take a look. Hold on, guys. I need something to point with, and my nails look a hot mess, so I don't want to keep pointing with my nails. Give me a second. Perfect. There we go. Acute dystonia. Sudden, sustained contraction, not relaxation, contraction of one or several muscle groups, usually the head and neck. This is a very serious, common extrapyramidal side effect that we see with the antipsychotics that you have to be concerned with. Two, akathisia. This is motor restlessness that causes pacing, repetitive movements, or inability to sit still or stay in one place. The third one, pseudo Parkinsonism. That word pseudo means like fake, not the real one. Pseudo Parkinsonism. So the patient will have those same symptoms of Parkinson's, but they don't really have Parkinson's, okay? So look at this. Temporary group of symptoms that looks like Parkinson's disease. We see the tremor, we see the reduced accessory muscles, like the swinging of the arms when walking. Guys, the reason that you swing your arms when you're walking, that helps you keep your balance. It helps you keep your equilibrium. In the pseudo Parkinsonism, we don't see that. You know how in Parkinsonism, the patient has a shuffling gait and they just walk like this, right? Their arms are not swinging the way they're supposed to. So it's easy for them to do what? Fall. Okay? Tardive dyskinesia. Tardive dyskinesia does not go away. It's irreversible. So this is very important to know. Tardive dyskinesia, this is a persistent. That means, that word persistent, when you see persistent and you're studying, guys, that means no matter what you do, it doesn't go away. It's a persistent extrapyramidal side effect involving involuntary rhythmic movements, usually after prolonged use of antipsychotics. So here's the thing with the tardive dyskinesia, that's why when patients are on these antipsychotics, we always start them at the lowest dose possible for as long as we can, right? Until the symptoms get worse, then we'll have to increase the dosage. But the reason why we do that, the longer that they're on those antipsychotics, the higher their risk for getting that tardive dyskinesia. Once they have it, we cannot get rid of it, okay? Look at this. It often persists even after the medication has been discontinued. This side effect usually begins in oral and facial muscles, and it progresses to include the fingers, toes, trunk, a neck, or pelvis. It's more common in women. Tardive dyskinesia varies from mild to severe, and it can be disfiguring or incapacitating. Other side effects of the first generation antipsychotics that you guys need to be aware about: sexual dysfunction, impotence, anorgasmia, impaired ejaculation, galactorrhea. Weight gain can be, where am I, guys? Weight gain can be more than 50 pounds per year, causing significant psychological distress and increasing the risk of cardiovascular disorders and diabetes. So if it was not enough that schizophrenic patient is already paranoid. They already feel like nothing's wrong with them, that they don't need to be taking their meds. On top of all of that, patients got all of these side effects that can potentially happen with those antipsychotics. How likely are they to be compliant with medication administration? Not much. Okay. Let's look at the side effects of antipsychotic medications. Important side effects you guys need to be aware of. Dry mouth. I don't know why I didn't put a star next to this, but it needs it right here. Encourage ice chips or sugarless candy. For testing purpose, sometimes it won't say dry mouth. It'll say xerostomia, starting with an X. Same thing. Okay, you're going to teach the patient to either suck on ice chips or sugarless candy. And the reason we say sugarless candy is because we don't want them to become a diabetic from eating all this candy. So we tell them sugarless candy or gum. Urinary retention and hesitancy. So you're going to encourage the patient to have ready access to the bathroom, and when they go, try to avoid, wait a second, and then try to avoid again, because they tend to hold on to their urine. Constipation, you're going to tell the patient to increase fluids, eat lots of fiber, to move around, because when you move around, that increases peristalsis of the GI tract. Blurred vision. With blurred vision, guys, what are we concerned about? We're concerned about safety. So we're going to tell that patient to make sure the areas are clear. We're going to make sure that they have good lighting. If they use glasses, to make sure they wear those glasses so that they're able to see. Dry eyes. We're going to teach a patient to use, the artificial tears, because if they don't and those eyes remain dry, the patient can have corneal abrasion or corneal ulceration. We don't want that to happen. And sexual dysfunction, we're going to tell them to talk to their healthcare provider about that. Maybe there is another medication or something else that the healthcare provider can do in regards to that. Anticholinergic toxicity. Those anticholinergics, those side effects: can't see, can't spit, can't pee, right? So think about all of those symptoms, except times 1,000 in overdrive. It is a potentially life-threatening medical emergency. Okay, patient has anticholinergic toxicity, and these are all those signs and symptoms. I'm not going to read all of them. You see them right here. Make sure you know them. What are you going to teach them to do? Hold all their medications. Remember, this is a life-threatening medical emergency. If they're already in anticholinergic crisis, anticholinergic toxicity, why would they still be taking those medications? Teach them to hold on medications. Implement emergency cooling measures as ordered, such as a cooling blanket. Urinary catheterization, that's for the urinary retention. Remember, can't see, can't spit, can't pee, urinary retention. Can't see, that's the blurred vision, decreased vision. Can't spit, that's the dry mouth. Can't pee, that's the urinary retention. That's the constipation, right? We're going to administer a benzodiazepine or other sedation as ordered. We want to avoid seizures. We do not want that patient to start having seizures. This medication, let me make this bigger so you can see. Right here. Physogostamine, this is an antidote to reverse the toxicity of the anticholinergics. You need to know that medication, and that medication needs to be on hand when the patient's taking those anticholinergic agents. Administer anti-Parkinson's agents, such as the Artane or the Cogentin. Because remember, one of the adverse effects of these antipsychotic drugs is what? Pseudo Parkinsonism. Provide a towel or handkerchief to wipe excess saliva. If the patient's having acute dystonic, where am I? Sorry, guys. Saliva, sorry. If the patient's having the pseudo Parkinsonism, let's talk about pseudo Parkinsonism. So besides them not being able to swing their arms, right? They may have that shuffling gait. They're at risk for falls. Another concern that we have with these patients is the high risk for aspirations. They have excess drooling. They're not swallowing the way they're supposed to. So we're concerned about aspirations, okay? Mask-like face, where the patient doesn't show any emotions at all. shuffling gait, drooling. Oh, I didn't talk to you about the pill rolling. You'll see them do something like this over and over and over again. And the reason they call it pill rolling, because it looks like they're rolling a pill. Okay. Dysphagia, we're concerned about them aspirating. Again, lots of salivation. Acute dystonic reaction. So we're going to monitor and assure open airway. Why? Take a look. Remember what those dystonic reactions were. Contractions, right? Look at this. Acute painful contractions of the tongue. Guess what? That tongue can include the airway, face, neck, and back. We're going to administer anti-Parkinson agents as needed. Prevent further dystonias with anti-Parkinson agents. Akathisia, again, give anti-Parkinson agents or lorazepam, Ativan. Teach them relaxation. This is the patient, remember akathisia, this is where they will not sit still. They cannot stand still. They have to be all over the place. They're restless, and we're trying to do what? Calm them down. We're trying to relax them, and that's why they may get something like Ativan, okay? And that's why we're teaching these relaxation methods. Tardive dyskinesia. The face, protruding or writhing of the tongue, blowing, smacking, licking, facial distortion. It's like, the best way I can explain it, guys, it's like they have a constant tick, where they might be like this, over and over and over and over, over and over and over again, okay? That's the tardive dyskinesia. It's purposeful muscle contraction overrides and masks the involuntary tardive movements. They cannot help themselves. They cannot stop it even if they wanted to. You're going to teach the patient ways to conceal the involuntary movements, such as holding one hand over the other. Hypotension and orthostatic hypotension. Hold dose and consult the prescriber if the systolic blood pressure is less than 80 when standing. You're going to teach this patient to dangle. You're going to teach them to change position slowly. If they're lying down, then they sit up, do that slowly. From sitting up to standing up, do that slowly, right? You're going to teach them to dangle. You're going to advise the patient to rise slowly to prevent dizziness and to hold on to railings of furniture while arising to reduce falls. When you guys do Parkinson's in med-surg, you'll see how much of a fall risk and safety risk this type of patient is. We see the same thing in schizophrenia because of the adverse effects of these medications. Agranulocytosis. This is very, very bad, guys. So agranulocytosis, look, the symptoms include reduced neutrophil counts, increased frequency and severity of infections. Why? Because those WBCs are severely decreased. Any symptoms suggesting infection, such as sore throat, fever, malaise, body aches, should be carefully evaluated. Okay? Those WBCs, those neutrophils that are made in the bone marrow are what? Severely decreased. Cholestatic jaundice, this is rare but reversible if it's caught in time. Symptoms, fever, malaise, nausea, abdominal pain, jaundice appears about 1 week later. You're going to teach the patient to observe for signs and symptoms of infection and report them properly. That's for the granulocytosis. For the cholestatic jaundice, bed rest, high protein, high carb diet if ordered, and liver function test, because guess what? When that patient's turning yellow because of that jaundice, what do we know is in trouble? The liver. Don't forget, guys, the liver is what's responsible for metabolizing and breaking down these medications, and the kidney is what's responsible for excreting these medications. So if they're not working properly, patient's at risk for a toxic amount of whatever the medication is that patient's taking. And that's it. We're done with schizophrenia. I think this was part 3 of schizophrenia. So guys, this was a quick video. Let me know what you thought about this video. Let me know what you'd like to see me cover next, if I haven't covered it already. And don't forget, almost daily, guys, I cover different types of nursing questions on my Instagram, TikTok, and Facebook page. I know I kind of went quickly on this video, but my kids got a soccer game literally in 10 minutes. And I'm here with you guys. So let me know what you guys thought about this video, and you guys will catch me on the next video.